Hello, everybody. Thank you so much for being here. Give us just a minute more as we continue to let the final people into the chat room, and we'll begin in just a moment.
Good morning to everybody. If you can just mute yourselves, unless it's your turn to speak at the end. We just ask everybody to just please mute themselves. Thank you. So good morning, good afternoon, and good evening to some of you. We welcome you to our second webinar on the GBY webinar series. Thank you very much for joining us. Just as an introduction, Global Black Youth convenes the world's most disruptive, innovative, and entrepreneurial young Black leaders and supports them in generating knowledge and solutions that transform their ability to impact the world. We do that especially in technology, innovation, entrepreneurship. We have 4 goals. The 4 pillars that we base our work on is launching a global discourse on racism and structural violence faced by Black youth globally. Reposition them as people with an untapped talent, a resource of talent and knowledge, and as valuable knowledge producers. Connect young Black leaders to each other and to various sectors of society in a cross-sectional and cross-regional way, and establish a pipeline between talent and opportunities. We're curating these conversations because we would like I said, to revalue and reposition young Black leaders as valuable sources of knowledge. And we would like to, we see that as an untapped source of knowledge that needs to be harnessed to respond, especially to the global crisis and pandemic that we're facing right now. And we're also tired of seeing a lot of the negative news from the global South and not seeing some of the positive news and innovative solutions that these young people come up with. So we are very keen on listening to our speaker today, and I would like to introduce my co-founder, Nyeleti Honwana, to take on the word from here. Thank you.
Thanks so much, Nusha, and good morning, everybody. Thank you so much. Well, good morning, good afternoon, and good evening, right? As we have a global audience. Thank you so much for joining us. As Nusha mentioned, the conversations that Global Black Youth is aiming to curate through this webinar series around how Black communities are responding to COVID-19 is really a global conversation. What we're looking to do is predominantly show positive innovations and work that's coming from the global South. But what you'll see here are representations, perspectives, and the realities of Black communities and young Black innovators, leaders, and disruptors from all over the world, right? And so we hope that this is a space in which these kinds of conversations can percolate, that you as an audience will engage with us and with our speakers. And so that I don't take up too much of your time, I'll finally go ahead and introduce myself properly. My name is Nyeleti Honwana, as Nusha pointed out. Nusha and I co-founded Global Black Youth, and along with a series of other projects, because I think we are serial workers in that way, Global Black Youth really brings together the various and myriad interests and foci that we have. So with that, I'll just go over a few housekeeping rules. This panel will run in three sections. Our first section will be a moderated panel discussion between our moderator, Lenice, and our 3 panel members, Katia, Gloria, and Vukosi. There'll be a back and forth between the 3 of them. We ask that during the panel, you use the chat function and write in questions and comments as they come up. What Nusha and I will be doing is collating some of these questions, organizing them, and sending them over to Lenice so that at the end of the panel discussion, the moderated panel discussion, she can present some of the major questions and comments that are percolating in the chat. This will go on for about 20 minutes, and then we'll close out the session, the final 20 minutes to 30 minutes of the session. So from 11 o'clock, we'll have an open discussion. And at that point, we ask you to raise your hands or use the raise your hand function. We will unmute you. You please ask your question to the panel members and to Lanice as well. And we'll have a kind of standard Q&A function for the final 30 minutes of the call. If there's any questions, if you have any comments, or if you have any resources, we ask that you write those in the chat, and we'll be as responsive in the chat as possible. We also ask that audience members who see interesting comments and questions in the chat also engage during that medium. With nothing else, I'll go ahead and turn the meeting over to Lanice Williams. Thank you.
Hi, everyone. Good morning, good afternoon, good evening. I know we're all calling from different time zones, different countries as well. Welcome to our panel today. So I just want to give a brief introduction to our panelists that will be joining with us. First, we have Dr. Gloria Prado-Pino from Colombia. She works with the State Committee for Prevention, Control, and Mitigation of COVID-19 in Chocó, Colombia. We also have Katia Mungwambe with the Eduardo Molan University and Mackay Health Research Center. And then we also have in Mozambique. And then we also have Vukosi Marvati with the University of Pretoria in South America. So, in South Africa. So each one of our panelists is just kind of going to give us an overview. So my first question that I have for my panelists, can you just talk to me about what is the state of COVID-19 in your country and community, a little bit about the number of people that are infected, and what is currently the state and healthcare response to this current situation?
I can go first. Hello, everybody. Thank you very much to Global Black Youth for inviting me to this panel. In terms of the current situation of COVID-19 in Mozambique, we have 104 cases so far. So the pandemic has a picture of a very incipient stage. It's clear that we are very limited in terms of number of tests. So massive testing has not occurred. And we see a focus or two clusters of transmission, one in the south of the country, which is where Maputo City is, the capital of Mozambique, and one in Cabo Delgado province, which is the furthest away province from Maputo, bordering Tanzania. In terms of mitigation, we are under state of emergency, level 3, with some limitations, but not in absolute terms. So Mozambique has declared the level 3 state of emergency, which was initially attached to closing down the education institutions and limiting the commerce, commercial activities. We stopped issuing visas, limited mobility, limiting gatherings now to a maximum amount of 10 people. And of course, recommending minimum distance, social and physical distancing, and reinforcement of education, communication, and information efforts for hand washing and other measures against the transmission. So this is what it is like in Mozambique in a nutshell.
Vukosi, can you currently speak to what's happening in South Africa?
Hey, hello everyone. I'm Vukosi, as was introduced earlier. I'm from South Africa. I'm the chair of data science at the University of Pretoria, and I'm also a visiting principal data science researcher at the Council for Scientific and Industrial Research. So in South Africa, we kind of had our first case reported on the 5th of March. So we are now kind of like two months and a bit into this, just like everywhere else. Started off very slowly in terms of the number of cases, and then we started having kind of an increase in our daily cases being reported, up to the point where the country then decided to go into lockdown. So this was on one part at the beginning, most of the cases were coming in or being imported into the country. And then once we did a lockdown, I think it was preceded by first not allowing any international travel in, or being very reduced. Then complete lockdown, meaning like, the economy basically ground to a halt. Very few people could go to work. Those would only be essential workers, healthcare responses and such. Then initially the first lockdown was supposed to last 3 weeks, then extended by two more weeks. And the country has now instituted having different levels of lockdown. So level 5 is the most restrictive, and now we've moved to level 4, where some sectors have reopened, or meaning people are allowed to go back to work, but then with social distance still being there, and the companies having to manage how employees interact within the companies. We do expect, as per the president's update last night, that by the end of the month, we should be able to go some parts of the country now, we'll be able to go down to lockdown level 3, which will be more permissive. And lockdown 1 is like very permissive, still social distancing, hygiene, and all those things. The thing is now we've moved away from imported cases, so people who are traveling, and we've moved to a stage where we're having community transmission. And this is the kind of thing that is really pushing the healthcare, this is going to be pushing the healthcare system. So initially you're playing kind of whack-a-mole, you're trying to identify somebody who might be positive, track and trace then who their contacts are, and then from there, you work to do quarantines and those. But through different issues, one being some of our testing turnaround time is very long. You would want to have ideally a turnaround time like 24 hours, 48 hours, so you can do track and trace can be effective. But right now, the numbers are between 5 and 14 days to get test results from the major national lab. And as such, the track and traces really becomes very much ineffective on that part. So I think we're like in the third phase of the pandemic in the country, where now the numbers are starting to accelerate again. So it slowed down after we went into lockdown, but now we're having community transmission. And one of our provinces, which is the Western Cape, is kind of having the fastest growth currently at the moment, with the largest proportion of the population actually testing positive. But it doesn't mean in the other places we don't have. It's just that they're still kind of on a point of still taking off. So we still have to see what might happen over the next few weeks.
Thank you. And Gloria, can you speak to what's currently happening in Colombia with COVID-19?
Yes, of course. I would like to share a presentation, small one. Let me, can you see my screen?
We can see it.
Okay. So in Colombia right now, we have more than 12,000 cases confirmed and more than 500 deaths. So our first case, we had in March the 6th, and we are approaching the pandemic in phases. So the first phase was about prevention, mostly prevention. The second was contention of the pandemic. And the third one is mitigation, because we have already community transmission. And we are like in that phase right now. But also we have one of our cities, which is Medellin, where the pandemic has been really well managed, and they're having a kind of suppression right now of the virus. So, first of all, I'd like to thank everyone for being here, listening to my presentation. And before discussing the impact of COVID-19 in Colombia, let me give you some context about the African descendant population in Colombia. According to the last census, Colombia's demographic was such as 86% of the population are non-ethnic, that is white and mestizos. This is the majority of our population. And about 11% are Black communities or people from African descent, of African descent. And about 3.4% are indigenous peoples. Furthermore, as you can see on this map, let me show you with this map, the majority of the African descendants are located along the Pacific coast of Colombia, the Pacific here and the Caribbean coast. So the states which are in the Pacific coast are four: Chocó, one of them, Valle, Cauca, and Nariño. So the African descent population is located mostly in this area, and Chocó is the state with the highest proportion of Black communities. So in addition, it was published by the Colombian Ministry of Culture that the African descent population also present the worst health indicators in the country. So if you were to see the highest mortality rate, infant mortality rate in Colombia, you will see it in Chocó. Maternal mortality, malnutrition, the worst indicators and the worst living standards in the country are in the Pacific coast. So at the same time, if we were to examine the electrical coverage of Colombia, one can see on this map that the Colombian Pacific region, Nariño, Chocó, Cauca, Valle, are the areas with the highest percentage of population who do not enjoy the basic necessity of having electricity in their houses. The blue dots on the map represent the areas not connected to electrical grid. It was published by the Colombian Ministry of Mines and Energy that the majority of these communities only receive electricity for under 12 hours per day. Even in Chocó, we have one of our towns which has only 5 hours per day of electricity. It's not a secret then that with no electricity, violence and crime rate in these communities are doomed to increase. And here it is important to mention that, so our previous president, he won a Nobel Prize because of the peace agreement for to end the armed conflict. But in the Pacific coast, the armed conflict never ended. Therefore, if we were to compare side-by-side areas of Colombia where the highest percentage of African descendants are concentrated versus the areas of Colombia not connected to an electrical grid, we see a direct correlation of this map. We can see here, this is the Pacific coast, and here. And this is alarming because I pose the question, what does this social economical situation of Blacks in Colombia mean when it comes to responding of the COVID-19? So So we will analyze this question by closely examining the current situation of the state of Chocó. So here we have our cases as of yesterday. So we have 40 cases, 40 confirmed cases. 21 of them are women and 19 of them are men. So 3 of them are dead. So we have, like, thank God, 4 people recovered so far. And most of the other patients are being treated at home. 2 of them are in hospital and 2 of them are in intensive care units. We have so far, so our state, Chocó, has 30 municipalities or 30 towns, and 4 of them have confirmed cases. So by ages, so we have from 0 to 27 patients, from 21 to 40, 13 cases, from 41 to 60, 15 cases, and older than 60 years old, 5 cases. So far is what I have to tell you. So in the next question, I can continue this presentation. Thank you.
Gloria, I know you spoke a little bit about the infection rates in Chocó. Could you just talk a little bit more about, you kind of highlighted how Afro-Colombians, particularly in Colombia, have the worst health outcomes, particularly when you look at Afro-Colombians within the Pacific Coast. Can you talk a little bit about how racial and class inequalities have exacerbated the spread of COVID-19 in the Pacific Coast of Colombia?
Yes. So we have, let me show you the map again. So what happened here is that inequalities are pretty, how can I say, like, I would say we have an structural violence in Colombia because this state is the only state, is not the only state, but it's the state with the highest proportion of Black communities, and also is the most impoverished state in the country. So it matched. So what happened is that the state has experienced historically an exclusion, a systematically exclusion by the central government. So we have, it can be observed by what I just mentioned, that I told you, that we have the worst living conditions. So we have a meat basic necessities in around 80%. So let me show you the next slide. So the opportunities also concentrated in the center of Colombia. So what happened with our cases, and why are there different from the projections that we have already made, is the lack of supplies. So we are lacking supplies to test people. We are lacking supplies to treat people in the hospital. So in the whole country, we only have, not in the whole country, in the whole state, we only have 6 ICU beds to treat patients with COVID-19, diagnosed with COVID-19. That's a huge difference from the rest of the country. So the challenge here is how to maintain the social distancing when people don't have food. So we have to provide that kind of food security in a region with 60% people living by the day in informal jobs. So this is I think the intersection with the social inequalities and the response that we have to make to COVID-19 pandemic. So this is the real challenge here, how to maintain social distancing in a region where we have no food security. I don't know if I respond to.
Oh, no, you responded well. Thank you so much. Yeah. And Vokosi, a question for you. Can you also talk a little bit about some of the inequalities that currently exist in South Africa that might make it challenging for people to social distance during this current pandemic?
Sure. Thank you for that question. Yes. So if we go back to the beginning of the lockdown, kind of one of the things we have to appreciate is the inequality in the country. So we still have mostly kind of apartheid kind of planned and implemented spatial planning. So you have areas that are very wealthy and you have very places like, that have poverty. So obviously, if you're going to now say that everybody has to shelter in place and stay in one spot, then you're going to have these challenges of really getting down to it that, yeah, some people can go and get food and put it at home and they can then eat on there, while other people cannot do that. They survived on, like, on having small daily access to money. Oh, sorry. A small, like, access to money or getting food by movement. So you would expect that those spaces wouldn't actually have. So through my time also working with the Gauteng government or the province that I'm in, these are some of the things we would note, that if you looked at more of the informal settlements, there was or still movement even after we had lockdown. Sure, on the first and second and third day, there's restricted movement, but after a while, people become hungry. They want to get food. They need to make money on that part, and that's why in South Africa, lockdown cannot go on kind of indefinitely. The government has been working to respond in multiple ways. So one is looking for vulnerable areas in terms of food, where there might be food deserts or places that don't have, are poor, and making sure that they can actually provide support in terms of food. In some other ways, I think probably South Africa now is rolling out one of its biggest social programs ever by actually giving out grants, even though they're still small comparatively to, if you look at the US, and trying to provide some money for the next few months so that people can be able to actually socially distance. These effects are going to be felt kind of for a long time. And I think the other thing then is to also think about, given the inequality, how the impact is going to be, especially on people who have other diseases. So if you have now HIV and you have TB and you live in a poor area, now if mobility is being restricted, you have to be very careful that those people still have to get healthcare. And if they're not getting healthcare, you don't want another strain of TB to be going around. So I'm a data scientist, and the way that we look at this, is through the data in itself. I'm not a medical, but then you try to then work with clinicians, you try to work with public health specialists to figure out what data or indicators they require to be able to quantify kind of this impact on people.
Katja, can you, given your work with the community response to novel treatment technologies, how can similar interventions be made in COVID-19 mitigations? And are communities currently responding to the current mitigation directives that the country has set in place?
Yes, as you pointed out, Lenice, I've been working on new tools for the prevention of mostly communicable diseases. And my role has been in terms of evaluating or assessing the feasibility of the introduction of these tools in the health systems. And I'm talking about vaccines, new treatments, and devices for disease control. And of course, lessons can be learned from having done work on the feasibility and acceptability. So talking about COVID-19, eventually, and we all want that a new treatment or a vaccine or a solution is found for the control of the disease. So no matter how simple the solution is, feasibility studies should be conducted in advance. And feasibility studies look at acceptability of communities to the intervention. They look at practicalities, issues related to barriers and facilitators for the implementation of this of the technologies, as well as the costs, both to families and to the government or to the state or the implementation partners. So all of these factors need to be taken into account alongside factors related to cultural and social aspects and the social position of the people who will be benefited from these interventions. Because as you pointed out, and my colleagues in the panel pointed out, inequalities are a big issue. So these really need to be taken into account so that the access, there are no disparities between social classes, for example, in terms of access to these technologies. So one of the things that would be different from assessing the feasibility and acceptability of new intervention for COVID-19 is that this process this time will have to be very fast. The pandemic is developing, evolving very fast. People are dying. Responses are urgent I mean, there's an urgency for responses to emerge. So doing research under these circumstances can be very challenging because of this time limitations. So I mean, in terms of lessons learned, I think these are some of the lessons that we could bring from looking into the introduction of new technologies in the context of other diseases. And we are the best people to provide. I mean, having lived in places where these diseases are communicable diseases have been responsible for most of the mortality of our populations. We are at the best position to convey these lessons learned.
Thank you, Katya. Thank you for highlighting, talking about the innovations that currently exist. My question that I have for the three of you, I'm going to ask Vukosi to answer this question first. Can you just talk a little bit about what are some what are examples of local health innovations you've seen or been involved with in response to COVID-19?
Okay, so again, being a scientist, I'll respond in one as a data scientist, and then from there, I'll try to also talk about some of the things that I've been seeing in terms of work on the ground from clinicians. So one of the challenges we kind of saw at the beginning of this, especially across the African continent, was we're going to have a problem with data. So the thing to look at it as is that for me, data is political. So if we're having a pandemic, at the moment, you can see how different countries have been responding to the pandemic actually spreading, and how in some cases political leaders have tried to either downplay or say that things are not as serious or people shouldn't be overreacting. So you should expect now that kind of smaller things like that are also going to happen in localities where now you want to be collecting data about the progression of the pandemic, right? So either individual cases or even aggregated numbers are going to be challenging on that part. But then when you add into it that you might not have health systems that are fully digitized, meaning that you can find out that somebody's actually died of something that might be COVID related, even if they weren't tested, but there's actually a suspicion, how does that then get into the system to get to a point that when you're tallying, you can actually what is this thing, highlight that kind of in a way. So in South Africa, what happened is that at the beginning, when they were doing testing and positive cases started coming, the minister was very kind of open about talking about every individual case. It was a male coming in from this country, this age, and they're based in this province. But over time, this became infeasible as a way to report these things. Because then if this is a PDF that's sitting somewhere, how then is this has actually become data that other scientists, other researchers can actually access and use for analysis, for modeling, for trying to actually mix in with some of their work to actually understand the disease. So even today, like, we don't really have a national repository that does this, that comes from the government. So what we did with a couple of researchers and also volunteers, we built then, to do it by hand, where people are reading these statements, they're looking at infographics that come from government entities, and then building it up in such a way that for other researchers, it simply is a machine readable thing that they can just fetch and use for South Africa. So that's grown a lot, and it's also then resulted in having a dashboard that we run that gives you kind of an overview of all of South Africa. I'll show it just in a bit. Then we did the same thing and said, like, okay, well, with collaborators in Boston University and other African countries, but even the person from Boston being like, an intersection of people from Nigeria, people from Ethiopia, people from Namibia, we then said we could do a similar thing, but for all African countries. So we then started another data bank or repository for African countries, so that once this pandemic is done, at least we have places where you can go in and be able to go back and replay what happened and work to build, to understand more and actually build up better responses in future. We're all going through this. It's just that now, if we just kind of put it at ourselves that if we didn't do this right now, it will be very hard to do it later, because it becomes harder and harder to be able to keep track of all of this data. Right now, we have, I think, over 20 volunteers who are always updating these things. Or it's not just like myself updating all this information, but we're trying to keep each other kind of going. On the health system side, yes, you do have now thinking about good ways to do screening. So where do you screen? I talked about this earlier, that because you have such inequality, you're very worried about community spread of COVID-19 in places where people can't quarantine. Like, simply, it's impossible. If you have a household where they have few rooms and you have 10 people living there, quarantining is very hard. So what you might want to do is be able to screen people quickly in real time and be able to identify that you might need reinforcements, you might need more people. So that's been something in South Africa that's come in, where people have come up with vulnerability indexes across the country, and then they've been using that to actually build in some of these other things. So yeah, I think for now that'll be.
Frank, I have a question for both Gloria and Katja. Can you just talk a little bit about what are some great examples of response you're seeing to COVID-19? And are there any lessons learned you feel like within Colombia or in Mozambique that the government can take on implementing those to mitigate the impact that the virus is having?
Okay. So here in Colombia, we have, so because of the differences and the health disparities that I just mentioned to you, so we have different approaches depending on the region you are. So in Chocó, so what happened is that we have lack of connectivity. So what we are implementing right now is a system of telemedicine. So we are providing these devices for helping doctors which are in remote areas, for the other doctors like in the urban areas, to provide them with support and with technical assistance. So that's one of the things. Also, with one of our institutions for the environmental protection. So we have these GIS people trying to tackle and to identify the regions with the highest risk of propagation of the virus. So with them, we are identifying the community at high risk. So that way we can test more people and identify them in an early stage. So the problem here is that we don't have a lab to process the samples. So we have to send them to Bogota, which is the capital city, to the National Institute of Health to process the samples. So we are working right now with the Ministry of Health, with the Ministry of Science and Technology for having our own laboratory to process the samples. So in that case, we would have the results like in a quicker, like in a better time. We can take some medical actions based on the diagnosis. And also what we are doing right now is various local organizations are also contributing by producing their own staff. For example, we have a robotics school and they are producing equipment for personal protection for physicians, nurses, therapists, and that way we can activate our own economy. Also, the University of Chocó, they are providing technical assistance to different group of people in the neighborhoods in the different towns, in different municipalities. So this way we identify community leaders to transmit, to communicate the risk, because not all of the towns have connectivity to internet. So we have to provide some of the teams to travel to those communities to do these interventions that I'm mentioning right now. What other things? Also, we are using this one. So with the help of the police department, we are using drones to inform people what is happening right now, to inform people how they can do self-protection, hygiene of the hands, all the importance of the social distancing and all the measures that are for preventing while we are preparing our health system with more beds, ICU beds, and also hospitalization beds, because we are lacking them right now. I think for now, that's most of the things that we are using, like in terms of technology and local innovation.
Thank you. Katja, I have a question for you. In Africa, traditional medicine has helped many poorer areas than the government has. Have you looked into indigenous knowledge for orientations, perhaps, as it relates to this? Or are they totally disregarding the know-how of informal skills?
Yeah, that's quite a challenging question. The Ministry of Health has within its organization system an Institute of Traditional Medicine. And this Institute of Traditional Medicine encourages initiatives. It's not just for COVID-19, initiatives related to indigenous knowledge to be put forth for, be it for research or dissemination of the knowledge that the indigenous knowledge has. So in terms of COVID-19, I don't have enough information in order to tell you whether indigenous knowledge is being used in order to in order to come up with solutions for COVID-19. And I think this could be something that to be encouraged, not only in Mozambique, in different parts of the world. And also not to look at traditional medicine as something that is that runs in parallel with the conventional medicine, but hand in hand. This is to say that not to discourage traditional medicine to be tested the same way as any other medication is tested and proven effective or efficacious before it is suggested for wide use.
Thank you. So now we're going to take some questions from the attendees. And one of the questions that I have, it's for you, Vukosi and Gloria. So as you've been hearing a lot, particularly in the United States, you've heard about different economic stimulus packages that are passing in the US, in Canada, in Europe, and a couple other countries. Can you talk a little bit about what policy measures the government has been instituting during or for post-COVID-19 situations? So can you talk about a little bit about how that is happening in South Africa and Colombia?
Thanks for that question. Yes, so the stimulus packages are covering both social and on the other side, which is the kind of general business. So we have interventions like providing stimulus packages to businesses through either loan schemes, working to have delays in specific types of payments, delaying kind of payments for tax. So actually giving, saying that tax doesn't need to be settled now for businesses, it can be settled kind of later. And then looking also at specific sectors. So having things for like the tourism industry has its own specific stimulus that they're trying to bring in and also assist. We also have for unemployment and assistance program to work for people who actually just be like, might be unemployed or just became unemployed. They can apply. That process is being streamlined. And I think one of the things in terms of innovation in this place has been how fast now there's been a movement to actually bring in technology into spaces of public service where prior it meant when you started thinking about planning, people would tell you about 5 years of implementation, where now it's because we're having to bring these programs in together, it's taking weeks or months. And this is not just across the stimulus packages, but also other spheres of government on that part. So, but if I look at it purely from a data science perspective, it has led to very interesting conversations that sometimes, if I go back like 3, 4, 5 years of me working in this area, people weren't really open to having deep conversations about, but now it has to happen. It has to kind of move on. On the side of individuals, we've always had a social grant system for people who are in poverty, people who might be disabled, for children and all those things. And now that's just either being expanded or also adding people who might just have fallen through the cracks for now, where they're much unemployed, but then we need to do social distancing. So that's still kind of going on. Though I did highlight the rapid development of technology, at the same time, given any country, this is still a challenge, right? Because what you don't want, though, is during this time where maybe a lot of regulations keep, because we're in a state of disaster, are put on the side, you're now seeing likely people taking advantage of this. So you want to make sure that government still keeps data sovereignty. They keep the privacy of citizens as a priority. So these are still conversations that still have to be had while we're rolling out these massive social programs across the country.
Gloria, can you speak to any economic stimulus or policies the government of Colombia is implementing to alleviate some of the financial strains for the citizens in the country?
Yes. So in Colombia, we have different kind of help assistance, or I would say it's been a crucial part of our strategies, the social assistance. So there are some programs for some of the people living in poverty. So one of these is Families in Action, Young People in Action. Those are like economic reward. No taxes for some people, elderly benefits. And we have also some percentage of the population who do not fit in any of this kind of benefits. So what we are doing is, so we are crossing the databases to identify who are not receiving any of these benefits. And for those families, the government is providing assistance by giving them the basic food, like the package, like packages for a month or 15 days. And also in the utilities, so some of the institutions, they are delaying the payments, and also some of them are not asking for payments during the pandemic, but also for these are only for some of the people who are living below the poverty line. Most of them is to encourage people to maintain in the houses, to keep the social distancing. And I think for most people, that's been like a good thing to maintain the measures, but for some sectors of the society, and especially here in Chocó, so we are having lately like many protests because people complain that they're not receiving what the government has promised to give them. So we are having social problems in the police department and the army. They're helping us to coordinate these aid, this humanitarian aid, but still we haven't tackled all of the gaps related to social assistance.
Thank you. So I would say, just thinking about what's happening, there's been a lot of conversations about how communities of African descent are heavily affected. From when we look at in the United States, for example, if you look at the COVID-19 virus in the state of Georgia, the population of African Americans is about 13%, but 80% of those that are infected or dying are of African descent. And one of the questions that came up from one of our attendees is, as we think about how people of African descent is being impacted by COVID-19, especially in Colombia, how did you come to, Gloria, how did you come to conclude that Afro-Colombians are highly effective, and what could that mean? And does it mean that health services are racially provided? You're on mute. We can't hear you.
Oh, sorry. So if you compare the cases, you can say, oh, they're doing great. But the problem is that I mentioned about the laboratory tests, so we don't have the opportunity to process them here in the region. And also we don't have enough supplies to test everyone or to test the people who are at risk. So what happened is that we are having some deaths that are not confirmed, and based on the projections that we have worked on alongside with the National Institute of Health. So we are really below the projections, but it's not exactly because we don't have the cases, but it's because we have lack of opportunity to diagnose them. So basically, and I would say, if you think about the whole country, in all the peripheral areas of the country, you can see that the cases are like, we have just like a few cases, but it's the same problem. Where you have the laboratories and where you have the technologies to diagnose, so you can identify more cases, but it doesn't mean that we don't have the cases here. And another thing is that since we're having cases of mortality, that is like a public health problem right now, because based on the protocols, we have to bury the bodies immediately, and people are not mourning, people are not like processing this pandemic situation. It has been really difficult for us. Even we had a case like 15 days ago in one of the public hospital. So the whole family went to the hospital, took the dead body out of the hospital, and they were running away with the dead body on the street. So we have this I would say denial behavior in the community, but it's because people don't believe that we are really like in the middle of this pandemic situation, and they think that these few cases is just because I don't know, the government is like making it up because we need money, and some people have thought that the more cases we have, the more money we receive from the central government. So they are spreading the word that those cases are not real. It's just something that we are making up to receive money. So we have like a lot of like a real work in the psychosocial area to do with our community.
Thank you. And I'm just going to ask one last question, and this question is going to go to Katya before we open it to our audience to raise their hands to ask questions. Katya, can you, as you know, there's been a lot of conversation about the importance of developing a vaccine to ensure that everyone has some level of immunity so that they can limit the number of new cases of COVID-19. Can you speak to a little bit about your current experience regarding producing, acquiring, and getting a vaccine, or can you just, or talk about what's the current process of developing a vaccine in Mozambique?
First, I would like to talk about this perception of immunity. Since in the very beginning, up to early March, most of the information that most people got came from the United States and Europe, and there was this misperception that people of African descent were not at risk. So this was a general misperception in different segments of communities in Mozambique. And also the fact that the first cases were imported cases, they were automatically linked to an elite who has access to travel, and the epidemic seems to have been contained within their circles. So this has exacerbated this perception or denial that this disease directly affect African and people of lower socioeconomic status. Here we don't have this issue of the racial issue, but it's mostly socioeconomic differences across people. So, and then the fact that in Mozambique, all of the cases have been, the majority of the cases have been asymptomatic followed by a very low number of a low proportion of symptomatic, but with very mild symptoms. It further exacerbates this perception that this doesn't affect Black people. However, we have our National Institute for Health and other research institutions working in the country have already positioned themselves and have already been open to conduct research on vaccine candidates, as long as there is the adequate biological plausibility for that vaccine to be tested. However, when you test a vaccine, and vaccines are being developed in different highly developed or highly industrialized countries. So one of the rules is that when you develop a vaccine, you first test on healthy individuals. And ethically speaking, it should be in the country where the vaccine is developed before it's deployed to other places where the vulnerabilities are higher, be it directly related to the disease, be it indirectly related to other issues such as poverty, low education status, etc. So should a vaccine be developed, obviously we would follow these principles, these ethical principles. But I would like to also highlight the importance of conducting acceptability studies of the vaccines, taking into account all of these factors of perceptions and misperceptions that people already have of that this disease does not affect Black people. And with regards to the social economic differences as well, I also would like to point out that although in the beginning the transmission is being followed based on these two clusters of the pandemic in Mozambique, we also have had an important movement across the terrestrial borders from countries which are at a worse situation than ours. So this is quite worrisome, especially if people are not aware of the risks, and especially because if we continue to have this asymptomatic behavior or pattern of the disease. I hope I managed to answer the question.
Yeah, thank you so much. So now we're gonna turn to our audience to ask some questions. However, just some housekeeping rules. We just ask you to use the raise your hand function first, and we will call on you from there, and just make sure that you unmute your phone, and you can direct your question either to Vukosi, Katja, or Gloria.
Okay, can I speak?
Yes, go ahead.
Okay, my name is Moses and I am from Kampala, Uganda. My question is addressed to, I think, all the panelists. One of the questions that I grapple with every day, people asking me, is in terms of the scientific evidence around the origin of COVID-19. And many of my colleagues are asking me whether this is a biological weapon designed by China in Wuhan laboratories to destabilize the US economy and the global, political, financial economy. So from the scientific point of view, I would like to understand what is available by way of evidence to show that perhaps this is a natural disease, a natural viral infection, and not necessarily a biological weapon to destabilize the global political economy, with which China and the US are the biggest beneficiaries. Thank you.
And I'm just going to take one more question from Jonathan.
So much. My question is related to the casualties and the statistics. Yeah, so far, I think we haven't had like really high casualties in Africa, and maybe that is still going to happen because we know the pandemic reached Africa quite late. Yeah, and but then the point is, given the low the general situation, my understanding is if people start dying in certain communities, you know, we would get the information somehow, because of course one cannot really rely on the official statistics, not just from Africa, but from all over the world, because the testing kits, there are so many related problems. But when people start dying in smaller communities, at least there would be some kind of, you know, people would talk about it, and eventually you would get the signal that something is not right. So the first question then is, if fewer people are dying in Africa, then are they doing something right, which we are not picking up? On the other hand, is something happening? You know, maybe these deaths are occurring, but we just are not getting. So something is happening, which I'm not so sure. And still it's a question which is open to the panelists. Yeah, thank you.
Thank you. I'm just going to take one more question. Her username is KPELLY. And can you just state where you're calling in from as well?
Yes, hello. My name is Didi Capelli, so you can just say Didi. So, and can you hear me? Yes, I guess.
Yes, I can hear you.
Okay. So I'm calling from Lomé in Togo currently. So can I go ahead with the question?
Yes, please go ahead with your question.
Like question reflection, yeah. So I'm just going to read what I wrote a little bit earlier. Is my question and reflection is, as many measures have been put in place to stop the spread of COVID-19. So we know that washing hands, social distancing, and all of those things. Has there been any studies on how these measures are affecting other diseases, usually transmitted in the same way as COVID-19? Because we know that COVID-19, is transmitted in when through cough, and I guess you all know how it's transmitted. But what I'm trying to get to is that other diseases are transmitted in very similar ways. So has there been any parallel, studies on how the fact that we've put in place those measures are also affecting the transmission of other diseases? And it will be interesting for countries, I believe, to study how some of the measures in place are affecting the transmission of other diseases, either in increasing or decreasing the prevalence of those diseases in the clinic and hospital. And I believe that such an analysis will help highlight the importance of hygiene, something that is very downplayed in our community. I'm calling from Togo, West Africa, and I've been in many of the West African countries, and a couple of just let's say before COVID-19, people used to wash their hands once every, generation. And now people are washing their hands once every 10 minutes. So hygiene has become something a little bit more into the culture. And can we use this COVID-19 situation to change habits and try to implement like long-term positive, habits in our people's life? And I believe that will also affect positively a lot of other diseases that are using the same route of transmission. So it was a little bit long, but it's kind of like question and reflection, and I'll be very interested to hear what you have to say about it. Thank you.
Thank you. Katja, Bokosi, or Gloria, I don't know which one of you want to go ahead and answer those three questions first, but feel free to respond to our attendees' questions.
Okay, I would say based on like a summary of all of your questions. Before I continue, thank you for asking. So we are being killed by inequalities because of the racism that we have to endure in our everyday life. So in Colombia, for example, this is a global problem. So everyone needs many things related to healthcare right now. So since we don't have well-equipped hospitals, we traditionally has to transfer patients to other cities and to other regions. So now, in this case, we are observing that obviously many of the other states are prioritizing their individuals. And we have seen this over the years. So they wouldn't put someone from a Black community in front of a person from other regions. So this is one thing. The other things related to other diseases is, for example, in our case, we are in an endemic area for malaria and dengue. So right now, those problems are worsening because people cannot mobilize as usual. So the medical mission are not doing what they do in a normal time. So basically, we have right now a community with more than 500 cases of malaria. So the intervention that we're trying to do is identify the cases at the same time, try to test people for malaria, for dengue, and for COVID-19. But this is a real problem because we have the highest prevalence of circulatory system diseases in Colombia, and we are not taking care of them as we would be doing in other times because of the lack of connectivity. We have, so related to the social distancing, we have this gap because we don't have connections in every place. So even for our people trying to be in social distancing means not having access to education because we don't have these programs online, we don't have the devices, we don't have the internet connection. So this is a real challenge as well in this pandemic situation because we have to, I would say, to balance how to attend, how to not neglect the other diseases and the other problems that we usually have, and also to pay attention to the pandemic cases.
Thank you. Vokosi or Katya, do you have any response to the questions from our audience?
Okay. Yes, I'll answer. So there's a couple of things. Sorry, I'm gonna try. I can't. Okay, I'm gonna try this, which is also a thing. So so one, I think there's a podcast for Moses' question called Science Versus, and it covers what was the coronavirus actually made in a lab, which I think it was this very pertinent question that came in. Obviously, this question also itself was politicized in terms of especially trying to assign blame. But it's very interesting in this in the podcast. It's actually scientists talking. And the nice thing about this podcast and why I listen to it as a scientist is that it also comes with a transcript of the podcast and they reference everything in there. So it's got 99 references. So you can go and actually check where all the scientific literature that they're talking about actually comes from. And basically, no, it didn't come in a lab. One of the things they talk about is that basically the design of the current, I mean, the way that the disease, I mean, itself or the viruses actually looks like looks like it will be a very sloppy design. So if somebody designed it, it would be somebody who didn't know what they were doing. While actually like people who work on viruses kind of know what to look out for to look like if it actually was made in a lab. That is one. So I'm just trying to move things around. The other question on like, what can the world learn from us, and then some of the things that are very kind of different. I wanted to highlight this. So Our World in Data has these very nice visualizations that anybody can go to. So ourworldindata.org, and they have a very nice COVID or coronavirus section that allows you to go in there. So what I wanted to do here was just highlight, looking at a couple of countries and specifically looking at comparing different regions. So yes, on one part, it is very interesting to look at the current mortality or case fatality rate. So how many people actually, like from the people who are diagnosed with COVID, even though that's not an exact number, meaning that we don't know what the background rate is, of the ones who are actually diagnosed, how many actually die on that part. So if you look at Italy there, it's at the top, it's very high. It's over 12%. You see Europe there is about 10%, and you can see how it's changed over time. And then the world is at about right now 7%. Now, if I looked at South Africa, it's down there at about 1.8%. Iceland is very small, but you can see if you say Africa, it's at about 3.53, so is Asia. So there are questions that then come up naturally of saying, okay, what is the difference between some of these locations and why the case fatality rates are actually small? And this is where then it becomes kind of a thing of looking at the environmental factors, looking at the social factors, looking at the cultural factors that are in there. And people are actively looking at those things. So it is kind of ongoing investigations trying to understand why things are there. And sure, Italy one is that you had a lot of old people, you have a very old population, and that's a big factor in that perspective. But there will be more that will come along. As I did highlight with kind of the work that we were doing, I said earlier, I'll talk, we were doing on trying to now collect data about South Africa, is that these data is going to become important as we're now trying to understand the final effects that we're going to have completely, or whether it's on our economies, on our societies, and those type of things. So there is still, we're not at the end. We are still kind of in this active part of this virus. So we ask questions. As a scientist, it means that we also try to make sure we communicate with the public and get the information out there. We don't want people to kind of be confused and all those things. And even when it comes to things like, oh, there might be a vaccine that's floating around. If you work in health and you understand what it actually means to make a vaccine, that's something where you're looking at 12 to 18 months. And as such, we need to kind of always put healthy skepticism to saying, okay, it's great that you think you have something, let it go to get tested before it gets rolled out, because you don't want people not seeking health, right? Because if they don't seek health because they're getting some intervention that is not even tested, then they themselves might die or even spread to many more people. So I think that's it for me. Yeah.
Thank you, Vukosi. And Katja, do you have one to respond to our audience question?
Yes, I would like to respond to the question on hand washing. And thank you for that question, because yes, hand washing is a very powerful tool, especially if it's done correctly with soap in the prevention of most diarrheal diseases. In fact, infectious diarrheal diseases, and a great number of fecal oral transmitted diseases, as well as other acute respiratory infections. So it's a very interesting research question to see, number one, if really hand washing frequency has increased. My sense, when I look around and see around, it seems like hand washing habits have increased, but there is the question as to whether this hand washing is being done correctly and at the critical times, because a critical time is when your hands are supposedly contaminated. So for COVID-19, unfortunately, critical times must be absolutely every time, all the time. Whereas for diarrheal diseases, it's just after you have touched fecal matter, for example, and it's something that you can tell as an individual by the behavior that you conducted earlier or immediately earlier. So obviously, yes, it will be a very good research question to see whether people are really hand washing with the desired frequency and whether that has impacted on the incidence of other diseases that are transmitted via dirty hands. In fact, I know of surveillance that is being conducted in all health facilities in Maputo City to see the incidence of other acute respiratory infections. And the influenza, for example, has gone up. So hand washing would have been something that would be impacting on that. So that tells us a little bit about potential links between current behaviors and other diseases. And that could be a proxy as well for hand washing. Another issue about hand washing is that in other places, not in Maputo City, we are conducted in Manisa Health Research Center, where I also work. We have been conducted an acute respiratory infection surveillance for the past 6-7 years in order to evaluate the impact of new vaccines to protect kids from acute respiratory infections. So platforms such as those ones could be used in order to monitor the evolution of epidemics or pandemics such as COVID-19. And I also wanted to add another innovation that we've been involved in is the minimally invasive autopsy, which is I mean, to the living, it would be equivalent to doing biopsies with fine needles instead of opening up a body to extract very small samples of tissue and fluids from the body to see what the person has died from. So I think this also could be an opportunity to use these techniques, and these techniques are being tested for their feasibility in Mozambique and other countries in Africa and in Asia, and incorporated into surveillance systems to see the evolution of different diseases, different infectious diseases. So COVID-19 could be one of the diseases to be incorporated in such surveillances. And with that, we could easily do, or relatively easily do correlations between disease outcomes, which is morbidity and mortality from certain diseases. In this case, from your question of one of the persons from the audience, diarrheal diseases and other diseases that can be controlled through hand washing, correlate those with hand washing frequency, monitoring of hand washing frequency in the homes. There are also various ways of conducting surveys, behavioral surveys, through which we can see the frequency of hand washing in the homes, in the hospitals as well. An important thing for an important place for us to monitor hand washing on hand hygiene habits is actually the health facilities, because in the health facilities is where people are at most risk of catching COVID-19. So I just wanted to bring this perhaps a little bit scattered, but points that could help us to reflect on the potential of hand washing, and the potential of hand washing not just for it to be a sustained habit for the control, not just of COVID-19, but also of other diseases that are really killing kids and adults alike in countries like mine.
Thank you, Katja. And we're just going to take one last question since we're running a little bit low on time. And that question is going to come from Arik. Arik, if you can just introduce yourself and say where you're calling from and direct one of your questions to one of our panelists.
Cool. My name is Arik. I'm from the UK. My question is about it's bringing it back to the disproportionate impact on people of color, Black communities. Just wanted to know whether this has come up previously in other viral outbreaks, and whether there's been any kind of political response after previous outbreaks? If not, is there a political movement or response happening in your country now? And is there any insights you can give for us in the UK, where this is also quite a big problem? Something like 4 times as many Black people are dying than white people from coronavirus in the UK, I think. And that's for anyone who's willing to answer it.
Vokosi, could you answer that question for us, please?
I guess this is very hard for me to answer that one. Yes, like, you know, if you look at the impact in South Africa of HIV and TB, it's mostly already in communities that are more like stricken with poverty in a way. So there was also the feeling when we saw this virus coming along that we're likely going to have the similar situation in terms of once we have community spread, the places that might actually fill up and have the biggest challenges are going to be those areas. And that's why what are these things? The vulnerability indexes were created to understand the socioeconomic and also kind of previous comorbidity information as to make it available to other scientists in making their decisions. But there are things that are good, like, you know, you can take from that. So our responses to TB and HIV, you can use those experiences now to learn actually for how doctors should actually be treating the onset of such a virus on there. And I think that's actually still going through. So you can see it that in terms of the clinicians, they've been looking at it and going back and then kind of looking at their playbooks from HIV and TB, and then working to put those playbooks into, like, you know, implement them as they are responding to this virus.
Thank you, Vokosi. And now I'm going to turn it over to Naleti and Nusha to
Thank you very much, everybody, for joining us today from all corners of the world, especially the chats. We had some extremely interesting insights, and we'll be able to upload the video and the chats on our website soon. We would, especially because this is the first time that we have a South-South conversation, really highlighting the similarities and challenges and opportunities with people of African descent in both regions. So thank you very much. We'll also like to thank our partners who have been extremely helpful in this, especially the Portland Institute, but as well as the Internet Without Borders, Open Think Tank Network, the Youth Cafe, Pan-African Council, the Global Business School Network, Web Roots Democracy, Civic Tech Innovation Network, African Diaspora Youth Forum in Europe, the University of Pretoria, and the ACP Young Professionals Network. So thank you very much, and I'll leave it to Naleti to wrap up for us. Thank you.
Thanks so much, Nusha, and thank you all for joining us again. I want to say a massive thank you to all of our panel members. I know it's late for some of you. This has been a fantastic conversation. As we mentioned at the beginning, it really is the beginning of a conversation. Both the video of the moderated panel discussion and our chat will be available on our website. We will continue to do webinars. We have a third webinar of the series on entrepreneurship and the economic impact of COVID next Thursday at the same time. So we hope that you will join us there. We will continue the conversation on social media via our website. So please do sign up for our mailing list. And thank you so much once again. Have a good rest of your week and a good weekend. Thank you. Bye-bye.
Thank you. Bye-bye.
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 Thank you. Bye.
Thank you. Bye.
Thank you.